Bacterial diseases acquired through the respiratory route. Chapter 4. Now remember, Chapter 4 is going to discuss bacterial infections, not necessarily bringing up anything viral. We're going to talk about some of the actual bacteria that causes upper respiratory infections. And you can have upper respiratory infections that are bacterial or viral. They could be acute, chronic, or recurrent. Typically, they're superficial. They're not. They don't spread systemically, so they usually just will stay at the site of the actual infection. For instance, pharyngitis, laryngitis, tonsillitis, sinusitis. So those are all infections of those particular parts of the upper respiratory system. Most often, the infections are preceded by the common cold. So a lot of times the individual is just kind of run down from the common cold, and it settles in some of these particular areas. And a lot of people, when they talk about chronic infections, a lot of people, when they get sick, one of these particular areas is where they will have a reoccurrent infection. A lot of people get sinusitis over and over and over again. People that have their tonsils, still have their tonsils, will get tonsillitis. So a lot of times, like I said, they just tend to be chronic in those particular areas. An extension into the eustachian tube from the pharyngitis can lead to odious media, which is an inflammation of the middle ear. And we'll see, I have a diagram in here, and we can kind of look at the diagram. There's also a diagram in your book. You can look at the diagram and see why the pharyngitis can spread into the eustachian tube, causing that inflammation of the middle ear. Bacterial pharyngitis and laryngitis are generally caused by the streptococci or Staphylococcus aureus bacteria. And I'm sure a lot of you recognize talking about streptococci, so that's generally associated with strep throat. Other agents or bacteria involved in sinusitis and odious media. So what that means is there are different bacteria, not necessarily the strep or the staph, that can cause sinusitis or the odious media. So looking at the diagram that is posted here, it's from McGraw-Hill book distributors, and it just shows a breakdown of the upper respiratory system. And I'm sure any of you that are respiratory therapists or dental hygienists are pretty familiar with this system, because it's obviously where you work at most of the time. But if you look on the upper right-hand side, you see where the nasopharynx is at. And then right below it, you see the opening of the auditory tube. Okay, so you can kind of see where, if you have an issue with actually any of these, tonsil pharynx, you can kind of see how it can all back up at some point and cause inflammation in the sinus. It can cause inflammation, like we said, in the eustachian tube. The drainage can come down from the sinus cavities into the tonsil area or the pharynx area and cause inflammation there as well. So this is it's a nice diagram, because you can kind of see exactly where everything is located in proximity with the upper respiratory system and how they're kind of all associated when it comes to bacterial infections. and how easy it would be for the bacterial infection to spread from, say the sinus infection to the tonsils or the pharynx or even the larynx. Incubation period for upper respiratory infections is usually 1 to 2 days. Human beings are the reservoirs for the organisms. And you'll see when we talk about infections that I usually try and tell you where the reservoir is so that you can kind of understand a little bit better who gets the infection or who's susceptible to the infection. So the reservoirs are human beings, and generally how upper respiratory infections are spread are usually through respiratory droplets. Person to person, and direct or indirect contact. And what that's talking about with respiratory droplets are, we've all been in a classroom where someone sneezes and doesn't cover their mouth, and all kinds of stuff comes flying out of their mouth. Although it's so tiny, it's almost in the form of an aerosol, you don't see it, it still contains the organism. So someone who's sneezing or coughing, that would emit the respiratory droplets, which would become aerosol, and the next person inhaling it would be susceptible to the infection. Person to person, that would be even, someone who's sitting next to you in class and they're sniffling and sniffling, and you breathe in what they're sniffling or blowing their nose, and you can be susceptible for the infection. And then direct or indirect contact, basically that means if you shake someone's hand who's wiped their nose or wiped their mouth, you shake someone's hand and maybe you touch your nose, the bacteria can be introduced into your system. And also, indirect contact would just be like we said, you're sitting in a desk, but the person before you maybe was sitting there that had a cold or an upper respiratory infection, and say maybe they sneezed on the desk or they wiped their nose and put their tissue on their desk, and you come in and sit down next. Indirect contact, but you came in contact with that organism, you're going to be susceptible as well to the infection. So some of the symptoms that are associated with upper respiratory infections, and we've all had these, you get a sore throat, difficulty swallowing, you can have pain in the larynx, hoarseness. Some people actually can lose their voice because of the inflammation. A lot of people just generally overall do not feel good. They have a fever, headache, muscle, joint pain. Because of the congestion, they have pain in their sinuses. We already talked about the eustachian tubes in the middle ear inflammation, which causes an ear infection a lot of times. Treatment, and remember we're talking bacterial infections. The treatment is generally an antibiotic. Now if it's a viral infection, we all know that viruses do not respond to antibiotics. So it's kind of up to the doctor to decide whether or not they think it's a viral infection or a bacterial infection based on symptoms a lot of times. And as we have said in the past, a problem with, people going into the doctors with these signs and symptoms, and before they're sure if it's a virus or a bacteria, they prescribe an antibiotic. And if it's a virus, obviously it's not going to do anything, but it is going to make your body a little more resistant to antibiotics in the future. So it's one thing I never, when I'm sick, when I used to teach in the classroom, I used to get a whole lot more sick because obviously, we're filled with 35 students, and in flu season, everyone was coughing and blowing their nose. But I usually really try and hold off on ever having an antibiotic, because when your body needs that antibiotic, it hopefully has not built any resistance to that particular antibiotic for it to be effective. So later in the semester, you're going to hear me talk a little bit about an infection I had in my elbow from an injection that I received that was a subcutaneous steroid injection. And what is believed to have happened is, instead of injecting it subcutaneous, she injected into the bone, and I ended up with osteomyelitis and bursitis in the joint, and literally the flesh opened up to the bone. And I was on antibiotics for that infection for almost 7 months, and a lot of it was trial and error to see, what the actual microorganism was going to respond to. And I honestly think if I had been somebody that took antibiotics on a regular basis, I don't think my body would have reacted, I don't want to say as well as it did, because I was on it for as long as I was, but I think that I honestly do think that there was a good possibility that I would have lost my arm due to the extent of the infection. So that's kind of one thing to kind of keep in your mind. A lot of people still want to go and have an antibiotic. It makes them feel better to say, I'm getting this treated, or I'm not going to be contagious. But you really have to know, and some doctors will even culture your sputum to actually see what organism is in there in order to decide what antibiotic to prescribe for you. The basic way of controlling upper respiratory infections is through good hygiene. So, hand washing, when you're out in public, making sure that you're coming home and washing your hands. If you do have an upper respiratory infection, be very cautious about when you blow your nose. Take the tissue, wrap it up, throw it in the garbage, and wash your hands. Don't sneeze into your hand and then touch other objects. If you don't have anything else to sneeze into, it's always a good idea to sneeze into the inside of your elbow, so that you're not going to be touching things with that to spread the infection to other people. So I said in the first couple slides that sinusitis can be caused by something other than the staph or the strep aureus bacteria. And pneumococci and Haemophilus influenza can cause sinus infections, which are two different bacteria. They are natural inhabitants of our body, and they become more active when our immunity is low. So that's why if you had the common cold, when we were talking a couple slides ago, if you had the common cold, your immunity is probably going to be a little low. You're going to be a little run down to begin with. This is why it can spread into sinusitis or a sinus infection. Okay, and a lot of times what happens with a sinus infection is the sinus passages get blocked, and they can't flow, so they can't release that sputum or mucus that's draining. And when that happens, then warm, dark, moist. I always say, I keep preaching, warm, dark, moist is just the perfect environment for bacteria to grow. So a sinus cavity would be a perfect area for bacteria to grow in some people. And like I said, some people just have chronic sinus infections. If they're going to get sick, that's usually how they get sick. I used to get sinus infections, and then about 4 years ago, I had a really bad tonsil infection where actually the one tonsil abscessed, and I ended up having to get my tonsils out. And since I had my tonsils out, I have like no issues with my sinuses at all, because the tonsils were so huge they were actually blocking the sputum from draining. So if someone has sinusitis, antibiotics are used, and there's a bunch of different antibiotics that are out there that work well with sinusitis. And also the book tells us to maintain a healthy lifestyle, which of course we know to maintain a healthy lifestyle. But you know, if you're sick, if you've had the cold, if you're run down, you know, you may want to take a little time to get better and build your immunity back up so that it doesn't progress into another type of infection. Streptococcal sore throat also can be known as pharyngitis. And when we talk about strep, all of us have had a strep throat infection at one point or another, or our kids have, or we recognize the symptoms of strep throat in our child and, you know, get them to the doctor right away, and they do a culture on the throat to make sure that it's actually strep. And strep really can be, it sounds like it could be, you know, get the child on an antibiotic and they'll be better. But if the strep goes undiagnosed, or if your child doesn't really exhibit symptoms, it can really cause some damage. It's associated with something called rheumatic fever and rheumatic heart, and also nephritis, which is of the kidneys. And basically what happens is, if that strep goes systemic, so if it starts to, you know, move through the bloodstream, it can affect the heart. And the rheumatic heart, it really, back in the day before we had regular use of antibiotics and regular, you know, accessibility to going to the doctor, people got rheumatic heart, and it damaged, usually their mitral valve was what was damaged. And most of those people ended up having to have the valve eventually replaced. Now, we don't see that often now, like I said, because we do have access to doctors and antibiotics. And if the antibiotic of choice is penicillin, well, penicillin is so darn cheap. Even if you don't have insurance, it's a really cheap medication to purchase. So you don't see the systemic effects of strep throat like we used to. Strep itself accounts for about 95% of sore throats. And if you've had, I've only had it one time in my life, and I had it, well, I'm sure I had it as a child, but we didn't go to the doctors very often. But I had it as an adult, and it was the absolute worst throat pain. It was terrible. And I mean, overall, I just felt so horrible. And I know when my son had it when he was younger, how lethargic he was. I mean, it really takes a lot out of you. Most common in children from ages 6 to 12 and from October to April. So you can see it's usually, you know, in the winter months. We're not outside. We don't have windows open. The kids are trapped in classrooms, and one child, you know, spreads it to another child, to another child. So you don't usually see it in the summertime. I mean, it can happen, but you don't usually see it. And about 20% of children are just carriers. They don't actually have the infection, so to speak, but they carry the staph bacteria, which they can spread to other children as well. Transmission of strep can be through direct or intimate contact or contaminated food. So direct contact we just talked about when we, a couple slides back when we were talking about the common cold. And that's pretty much, you know, you're one-on-one with somebody, the kid has strep throat, sneezes on you, wipes his nose, touches the desk, coughs, that type of thing. Intimate contact also would be sharing food, eating off of one spoon and letting someone try what you're eating, kissing somebody. If that person is a carrier or that person has strep that has not activated yet, chances are very good that you can get it. One of the things about strep that's kind of a tell-all is the individual gets a temperature, and that's where where you just feel so crappy because, especially as an adult, if you get a temperature of 100 even, you feel really bad. And with these little guys, they can go anywhere from 101 to 104, and some cases even 105. As I said earlier, that they tend to, if it's a sore throat strep, because we can get strep, like we said earlier, we can get it in other places, but if it's a sore throat strep, they have a very severe. It's different than any sort of a sore throat of just having sinus drainage or having a little bacterial infection. It's a different sore throat. It's very painful. Swollen glands, we know our lymph nodes work super hard to try and remove bacteria from our system. They'll get really engorged because they're trying to work, especially the ones in our neck. If you still have your tonsils, they get enlarged because remember our tonsils are lymph tissue as well, so they're going to kind of swell up as well and try and help with some of that inflammation. The other thing that the person feels is they feel just really horrible, bad, malaise, they're weak, they're achy, no appetite. They can get a rash. The rash a lot of times can progress into rheumatic fever. That red rash that when my son ever got strep throat, before he ever complained about his throat hurting him, he always had a rash and a really upset stomach. And those aren't typically the first signs, but they're definitely signs of strep throat. The strep has basically not developed much resistance to any antibiotics. So strep is still pretty treatable. PCN or penicillin is still very effective, which I said earlier. That's generally they're going to use a penicillin or a derivative for strep throat, and usually 10 days of treatment for it as well. And if not treated, it can go into rheumatic fever, which we just talked about, which they get a really bad rash, and then it affects the valves of their heart. Next, we're going to talk about pneumococcal pneumonia. The etiology of pneumococcal pneumonia is Streptococcus pneumoniae, which once again is strep-related bacteria. It's most common, the most common cause of pneumonia, and you see it most in young and very old. It's also common cause for death in alcoholics. Its natural inhabitants are in the upper respiratory tract. The incubation period is 1 to 3 days. With antibiotics, the patient becomes non-infectious in 48 hours. Transmission of pneumococcal pneumonia is respiratory droplets, once again, and direct oral contact. So that would be the same thing again as kissing somebody, sharing food with somebody. The symptoms are very sudden. Patient will have chills, fever, they'll have chest pain from the sputum that's in their lungs, they'll have difficulty breathing, a cough, red sputum, which is blood-tinged sputum, and a lot of them will get pleurisy, which is an inflammation of the lining between the chest cavity and the lungs. Very painful to have pleurisy. It's not, you're not going to just feel it when you cough. The pleurisy is there. It's very, very painful. Pneumococcal pneumonia can be resistant to some antibiotics. So what is recommended is a vaccination for the elderly, people that are immunocompromised, debilitated people, people that are in nursing homes, and alcoholics as well. According to the CDC, pneumococcal conjugate vaccine is recommended for all babies and children younger than 2 years old, all adults 65 years or older, and people ages 2 through 64 years old with certain medical conditions. So conjugate, remember, is a mixture. So it's a mixture of a mixed vaccine of a couple different substances. Pneumococcal polysaccharide vaccine is also recommended for all adults 65 or older, people ages 2 through 64 who are at increased risk for disease due to certain medical conditions, and adults 19 through 64 who smoke cigarettes. Mycoplasmal pneumonia is also known as walking pneumonia, usually seen in the lower respiratory system. It is a dry pneumonia. There's no exudate. When the individual coughs, it's a dry cough. You see it more frequently in winter months. The incubation period for it is 2 weeks. So remember, when we talk about an incubation period, that's how long it takes to grow. So you could actually be in contact with someone 2 weeks ago and just now start coming down with the infection. And I apologize that my email keeps going off, and that's how many emails I get constantly all day long. So if I don't get right back to you when you send me an email, it's because I have so many of them to go through. But I apologize for the noise in the background. Symptoms are a dry cough, a headache, malaise, and substernal pain. So pain in the underneath the sternum, the individual will have. It can last for days to a month or even longer. It's a very long, drawn-out infection, and generally the antibiotic of choice is going to be tetracycline or any of its derivatives. The next bacterial infection we're going to talk about is Legionnaire's disease. I'm sorry, of the respiratory system. And Legionnaire's disease was really first discovered or recognized in Philadelphia in 1976. And I can still remember this being on the news because they had no idea why all these people were getting sick that had been at a conference. And so they had all these people that were coming down ill, and they couldn't figure out what was causing the infection or the illness in these people. And out of that, I think there were, if I'm not mistaken, there were 5,000 people at that conference, and 182 people were hospitalized, and 29 of them died. And remember, a lot of times when these people that passed away, they may have had, they might have been in a weaker, not a strong, healthy person, but also at the time we had no idea what it was or how to treat it. So it was kind of a hit and miss on treating these patients. And what they determined was that this bacteria, this organism, was found in the cooling towers of the hotel, so where the air conditioning was at. And it's called Bacteria Legionella. And at that point, they were able to actually put a name on it. And from there, now remember, back in 1976, as hard as it is to believe, the majority of people didn't have air conditioning. The majority of people, had fans in their windows or screened-in windows. So this was kind of a new thing where, now we're seeing air conditionings, and now we're seeing this particular bacteria present itself. There have been a couple other cases where at a grocery store, the misting that they do on the vegetables and the fruit at grocery stores, that's all very cool. It's cold and chilled. They have had cases where it's been found in there. And also there was a case on a cruise ship in a whirlpool that the Legionnaire's disease presented itself. Once again, as you know, warm, moist conditions, and also the reservoir can be in soil and in water. So all these conditions were correct for Legionnaire's disease or Legionella growing. With the air conditioning and the whirlpool. Okay, so water, that's where the majority of the individuals that are affected, it has something to do with warm, moist conditions, which would be your whirlpool, and water, and also in the soil. And the transmission of Legionnaire's disease, like I said, is faulty air cooling systems, cooling towers, or excavation sites. So if it's living in the soil and someone's working on an excavation site where that's living and the soil gets tossed up, it can become airborne, and the individual inhales the bacteria, and that's how they end up with Legionella. That's why some of the air conditioning systems and the water systems, they have to be disinfected for that reason, because it's a perfect environment for Legionella to grow. And so the only way that's known to contract it is through inhalation of the bacteria. Okay, so it's airborne. There's no evidence that it's spread from person to person. Now, let the convention that we were talking about, they started thinking it was being spread from person to person, but it wasn't. It was everybody was in this same room inhaling this bacteria. The symptoms, diarrhea, anorexia, just being overall sick, malaise, weak. They have some neuralgias that go on, headache, fever. Some can be up to 105, so you can imagine how sick you would be. Chills, a non-productive cough, and then the cough will turn into a grayish, blood-streaked sputum. So initially it starts out as just a dry cough, but as it progresses, you do end up with a gray, like, kind of blood-streaked sputum. Erythromycin is usually the penicillin of choice, and if need be, there's another drug called rifampin that may be added to it. Now, when I had the elbow infection, it kind of all came down to like I said, one of two things, or it could have been both. The initial thought from the infectious disease doctor was that it was contaminated Kenalog, which is the steroid, or they used tap water to break the Kenalog down, because a lot of them come in a concentrate and they should be broken down with sterile water, and they thought maybe they used tap water. And what ended up actually getting rid of the microbacterium that I had was rifampin, and it's a really, really strong, harsh drug, but definitely was effective in my situation, and it is in these cases with Legionnaire's disease when somebody has a very bad case of it, and the erythromycin itself isn't doing a whole lot for the person. And you'll see when we talk about tuberculosis, rifampin is usually the drug of choice for tuberculosis as well. And like I said, the cooling towers where the water is being cooled needs to be disinfected, because if it's not, that's just, like I said, it's just a prime opportunity for Legionella to grow. Next, we talk about pertussis, which is also known as whooping cough. The etiology of whooping cough is the Bordetella pertussis, and it's a bacillus. So, you know, a bacillus is our shape of our bacteria. Once the cough begins, the individual is really contagious for 3 weeks. It's highly communicable during the late incubation and in the catarrhal stage, which is basically when the mucous membranes of the head and throat are most inflamed. That's when the patient is most contagious. Once antibiotics are started, 5 to 7 days, the individual is no longer contagious. And pertussis is part of our childhood vaccinations that are required by law. Now, a few years back, we had an outbreak of whooping cough, and anybody that was going to be around an infant or a small child that was an adult needed to be revaccinated, because we're seeing now in this next generation where our immunity to certain vaccinations has worn off. So just to be safe, the CDC came out saying that anyone that was around or going to be handling infants or small children needed to be revaccinated again. Next is diphtheria, which is another infection of the upper respiratory system. It produces a deadly exotoxin, which is a toxin that's emitted from the bacteria. It irritates the tissue, creates a pseudomembrane along with swelling. It can occlude the airway, and the individual basically suffocates to death. So you can see why this is another vaccination that is part of our childhood vaccinations, because it is potentially deadly. So it's not the bacteria itself that causes the sickness, it's the exotoxin. Okay, so the toxin that the bacteria releases that irritates the tissue and creates the pseudomembrane. And a pseudomembrane is basically not a connected membrane. It's pseudo means fake. So it's kind of a membrane that's not connected, but it's there. Okay, so it can be removed basically. The toxin can eventually spread to other organs in the body, including kidneys and liver, which causes death. And the reservoir for diphtheria is humans. The incubation period for diphtheria is 2 to 5 days, and the individual can be communicable for up to 4 weeks. They can be contagious. Once you have diphtheria, you're a carrier for life. So you will always carry that bacteria. It doesn't mean it's active, but you'll always carry it. Infants have passive immunity for 6 months. And at that point, then we do start with our vaccinations for the children. I believe they start at 1 month and then 3 months. Don't quote me on that, but I believe that's when they start. But mom passes that immunity on for 6 months in case, and that goes back to how the cool our body is, basically, that if the baby, back in the day when they didn't have the vaccinations, the baby would be less susceptible to getting diphtheria if they came in contact with somebody that had it for up to 6 months. Just because you've had diphtheria, it does not mean that you're immune to getting it again. So an attack does not confer immunity. It does not mean if you've had it once, like we talked about before with the chicken pox, if you've had it once, you usually will never get them again. That's not the case with diphtheria. The transmission is through direct contact, droplets, and indirect contact with articles that are soiled with discharges from the infected person. So that could be anything. That could be tissues, baby bottles, cups, anything that has been in contact with the person who's sick or who's has the infection. And finishing up with diphtheria again, milk that's been contaminated after pasteurization or raw milk may also serve as a vehicle for that particular bacteria. The symptoms are a thick, patchy, grayish-green membrane that forms over the mucous membranes of the pharynx, larynx, tonsils. That's supposed to say soft palate in the nose. So once that pseudomembrane covers all the areas that we need to breathe, basically, they suffocate. So some of the other signs can be fever, sore throat, a raspy cough. It could be hoarse. and it does have the potential of becoming systemic. Antibiotics can be used, but the best method is prevention, and that's in our childhood vaccination as well, with the DTP vaccination. So that's diphtheria, tetanus, and pertussis is what DPT or DTP means. And next we'll talk about tuberculosis. And tuberculosis is a mycobacterium that is what I told you was decided on, that is what I had in my elbow, hence why the rifampin was used as well. And also remember, when they first injected my elbow, it was about 10 injections I got subcutaneous. It actually was a little rash that I had on my elbow. Remember, that went underneath the tissue, and what kind of an environment is that? That's a nice, warm, dark, moist environment, which is a perfect breeding ground for bacteria and mycobacteriums. Same with the lungs. Warm, dark, moist. So that's where you're going to see a lot of infection because of its environment. And it's the same with tuberculosis. Tubercle bacillus, it's an actual bacillus bacteria. It can be acute, but most often it's chronic, meaning you have it, you're going to have that for life. So when you have your tuberculosis skin test and you're reactive, most of us are not reactive because the majority of tuberculosis has been completely eradicated in the United States. It was almost completely eradicated until we started seeing patients with HIV back in the 80s who were immunocompromised, and we have transcontinental transportation. So we can go from country to country on an airplane, and places that still have tuberculosis, someone can come back as a carrier and be in contact with another individual and give that to that person. So that's why I was telling you that when I did work in the dental hygiene clinic at YSU, every year I had to have a tuberculosis skin test to make sure that I was not a carrier and could potentially spread that bacteria to any of our patients, and our students had to do the same thing. When I worked at the prison as a dental hygienist, I told you we shut the whole prison down for one whole day, and everyone went out and did the skin tests to see because think about a prison in the closed quarters that you're in, and if a couple people or even one person has tested positive for TB or tuberculosis, then that individual, there's a protocol that needs to be followed through with as far as chest x-rays. They look at lesions on the chest to see if there are lesions in the chest, meaning that the patient has had it in the past, or are they just a carrier of it. So that's why the tuberculosis skin test is done every year on, they do it in nursing homes, they do it in any sort of institutionalized area. They want to make sure that one person doesn't have it and it's going to end up spreading to the rest of the population. Humans are the primary reservoir, but it can affect cattle. And naturally, kind of put it in your mind when we do take our tests and our quizzes, that for the most part, anything that you see from the upper respiratory system is one of the ways it's going to be spread is through respiratory droplets and aerosols. Okay, you can have tuberculosis and think you're rid of it, but it can reactivate. And the protocol for tuberculosis is taking rifampin, which I told you is an antibiotic, and that's what I took for my elbow, and I was on rifampin for about 6 months. Rifampin, the protocol is 9 months on somebody who has tested positive for tuberculosis. And what happens is rifampin is such a difficult medication to take. The only way I could describe taking that medication was having chemotherapy without the support that you get when you have chemotherapy, because I was so sick 24 hours a day, 7 days a week. And it lasted for even months after the rifampin. And what happens is a lot of people, because they're so sick, they do not continue with the treatment. And then what happens is, so they might have already started responding to the rifampin, starting to feel a little bit better, or they're super sick from the medication, not from the tuberculosis, and they stop taking it, and now our body starts to regenerate that mycobacterium again. But now it's smarter, the mycobacterium is, because you haven't gotten rid of the bacteria, and now you're going to stop taking your antibiotic, and when it comes back, the bacterium is going to say, hey, I recognize that antibiotic, and it doesn't do anything for me now. So that's why the bacteria basically outsmarts the antibiotic, and when it comes back, it's next to impossible to treat because of that, because there's nothing left. And I remember them telling me, now remember, I did not have tuberculosis. I had a mycobacterium, but not the tuberculosis mycobacterium. It was a different one. But I remember him telling me, whatever you do not stop taking the rifampin. And it was the last ditch effort of antibiotics for them to try on me, and that's what ended up working. And like I said, I was so incredibly sick, and my resistance was so low from being on every single antibiotic that I was sick with, you name it. I hadn't had a flu or a cold in years and years and years. I hadn't even been on an antibiotic in years and years. And as soon as I finished taking the rifampin, I got influenza B. 4 more weeks I was so sick. Then I had to be on an antiviral medication. And then as soon as I was done with that, then I got Lyme's disease, which we'll talk about later on when we talk about different skin infections, which then I had to go back on antibiotic again for another 21 days. But my resistance was so low from so much antibiotic that I was susceptible to a lot of other infections as well. But the problem with tuberculosis is, remember, we had almost eradicated it in the United States, and then we had a resurgence again of tuberculosis with these immunocompromised patients, definitely associated with HIV patients, okay, because of the fact that we have transcontinental travel, individuals going from one country to another where tuberculosis is prominent, and the individuals that are immunocompromised, can get the tuberculosis from, someone who's a carrier or someone who has it in an inactive state.